So Vic Patel already showed you the technique, and I'm going to talk about a couple of aspects, no conflicts. So if you want the best summary review of approaches to the SI joint, it's this article. So Vic Patel already showed you the surgical technique, and I'm going to talk about a couple of aspects, no conflicts. So if you want the best summary review of approaches to the SI joint, it's this article by John Stark. And he has some great diagrams in there that kudos to him for that discussion process. Here's the piece that I want you to really take home. This is the article I mentioned earlier, sacral bone mineral density. Every strategy that we've come up with to date will have failures. The rate at which we'll have failures, I don't know, but we will have failures. And I am willing to put money on the table. The failure will always be on the sacral side. Unless you acutely fracture the iliac wing is always so much stronger than the sacrum that it's the sacrum that is the problem. How can I point that out to you? Well, if you look at the regions of bone density within the sacrum, the area that's probably the safest to go into because of lack of neural elements is sort of right in here. And it's also the area with the lowest bone density. So how do we put this into context for you? So this is the L1 opportunistic bone mineral density. Goes back to the article by Pickart in Annals of Internal Medicine in 2013. And if your Hounsfield units are 135, you're normal. Okay, there's some variation dependent upon the CT technique. And so we took CT scans where we had L1 through the sacrum, people who had kidney stones, who got scans looking at their kidney stones, and compared the density at L1 to the density in the various regions in the sacrum. And the point is that the central ala, the density is like 0.25 or 25 Hounsfield units. And so that where you place your device profoundly matters, and it's highly variable patient to patient to patient. And so the challenge of how do you do this without 3D navigation, I don't think you can glibly say do A or B. It's going to be variable based upon the sacrum. And the sacral side will always be the problem in all of the strategies described. Okay, so all right, it's not advancing. Max, it's not Max. It's not advancing. Thank you. All right. So what I focused on for my 5-minute spiel was what are the results, and so the data about a lateral approach is the one that's most published on, for which there is the greatest data. Whether it's screw-based or triangular rods, we see the persisting graphs of the joint pain and the ODI improvement with durability out to up to 5 years now. Long-term relief in 3 studies, visual analog scale improvement, again, consistent pattern, consistent pattern. And then when we look at ODI improvement, depending on what you use as a threshold, you see the vast majority of the studies reach minimum clinically important difference, and patient satisfaction rates are also high. So what does the data say? The data to date supports the lateral approach. I think other options exist, and I genuinely look forward to meaningful data from the other approaches. Thanks.